Let me introduce myself first. My name is Ruth Biller. I'm living in Munich in Germany. 30 years ago, I became a gynecologist without knowing that my husband had ARVC, arrhythmogenic right ventricular cardiomyopathy. Otherwise, I would certainly have become a cardiologist. After the death of my daughter Judith in 2011 from ARVC at the age of 14, I started an ARVC self-help group with my husband's family in 2013. Since 2018, I'm chair of the registered non-profit association ARVC-Selbsthilfe and member of the European Patient Advocacy Group called EPAC of ERN, the European Reference Network Guard Heart. For 1.5 years, I'm chair of the EPACs. I also advise parents whose child has died of sudden cardiac death for the Compassionate Friends Munich. I'm closely working together with Esther Costa-Freda, chair of Síndromes Arrítmicos Relacionados con la Muerte Súbita, who is former chair and present co-chair of the European Patient Advocacy Group. You may have seen her last year. I have a dream. I have a dream that doctors, patients, and patient advocates will be able to sit down together at the table of brotherhood. A slightly modified quotation from Martin Luther King, whose famous speech is very relevant again, especially in these times. Doctors are experts for rare heart diseases. Patients are the experts of living with rare heart diseases. Together we can change the world for the patients. I have a dream that patients with rare disease are diagnosed within a year. Long diagnostic odysseys must be avoided. I have a dream that psychosocial support becomes an integral part of medical care. We need psychologists by the side of cardiologists and geneticists. I have a dream that patient advocates are part of guideline development. The patient's perspective must be implemented into guidelines. I have a dream that patient advocates are partners in registries. Patient organizations should get access to the data of their members. I have a dream that the patient's view is integrated into medical pathways. We need a holistic view and not just the focus on medical problems. I have a dream that more patient-centered information is provided. For the benefit of patients, we need better training of non-specialist doctors, more educational talks on rare heart diseases at congresses or online courses. We need more public awareness of rare heart diseases, big campaigns in all media. We need more research on rare heart diseases, driven by patients' needs. We need better access to expert knowledge. And we definitely need molecular autopsy, which means autopsy and genetic testing, in case of sudden cardiac death in the young, below 40 or 50 years. Patients and patient advocates can contribute to the education of doctors by talking at congresses and conveying the patient's perspective. We can create awareness by patient stories in newspapers or magazines. We can spread the knowledge about expertise, for example, about specialist centers, centers for rare diseases, centers being member of the European Reference Network. We can help to integrate ERNs and expert centers into national health systems by getting involved in health policy. We can initiate and support research projects with a patient-centered approach. research that is focused on patients' needs. My organization does support research with a PhD scholarship for young researchers. We can guarantee access to experts' knowledge for more hospitals and for patient organizations. Doctors should think of inherited heart disease in every patient with unexplained arrhythmias. Doctors should think of inherited heart disease in every patient with unexplained syncope. Doctors should take a detailed family history. Always ask about cases of sudden cardiac death in the family, especially at young age, below 40 or 50 years. Doctors should do 12-lead ECG, ambulatory ECG monitoring for 24 to 48 hours, and MRI in suspected cases, or transfer patient to an expert center in case this is not possible. Doctors should consider genetic testing in any unexplained case if there is no definite diagnosis. Doctors should transfer patients with unexplained symptoms to a specialist. For example, Centers for Rare Diseases, ERN gut heart specialists. Patients need questionnaires that really measure the psychosocial needs of patients. They need psychosocial support after diagnosis and at any time when important decisions are made. For example, implantation of an ICD or heart transplant or whatever. Patients need sufficient time for questions and advice, and appreciative communication between doctor and patient. Patients need accompanying measures that help patients to cope with the disease. They need supportive tools that carry through acute crisis. They need psychologists specialized on heart diseases. In Germany, we call them psychocardiologists. Patients need long-term psychological support nearby and without long waiting period. They need respect for the different ways of dealing with the disease. We would like to see questionnaires implemented into medical care. We need the acknowledgement of PROMs and PREMs, that's patient-reported outcome measures and patient-reported experience measures. We think it's important that outcomes are not just focused on medical results, but on quality of life. We need training of psychologists who specialize in rare heart diseases. We need psychocardiologists, like the already established psycho-oncologists. There should be a collection of helpful measures to reduce psychosocial stress. Patients need guidelines that meet the needs of the patients. They need guidelines that don't just focus on purely medical issues. They need guidelines with recommendations for everyday life. These guidelines are to be followed by all doctors treating patients with rare heart diseases. The participation of patient representatives and patient organizations in the development of clinical guidelines or any other clinical decision support tool, like consensus statements, position papers, etc., should be mandatory. We would like doctors to recognize that patient representatives can make a valuable contribution to guidelines. It would be for the benefit of patients that registries are built with patient advocates as partners. We would like to have access for patients or patient organizations to registries. Registries could be built where patients or patient organizations can provide data themselves. The data of the registries should be usable by as many researchers as possible, as long as the research is done for the patient's benefit. We We would like to see the involvement of patient organizations in registry task groups. Patient organizations can recruit patients for registries. Patient organizations could help experts enroll patients into registries. And patient organizations would like to be patient advocates as partners who can use the data of the registries for the benefit of their members. Patients need patient-centered pathways with a focus not only on the diagnosis. Patients need information about the disease and implications for their relatives. Patients need advice not only about medical issues but also about social issues like driving, lifestyle, sports, insurance, school, work, or traveling. Patients need specialized psychologists and specialized rehab centers. Patients need a cardiologist nearby who is willing to do the follow-up but refers to a specialist if necessary. Patients need always the same contact person. The past medical history of patients with rare heart diseases are far too complex to be told from the beginning every time. We need working groups of experts and patient advocates to implement the patient's view into medical pathways. What do patients need during their way through the diagnostic and therapeutic pathway? We need a better organization of medical consultation, all with the same doctor who is familiar with the case. We need a trusting network of doctors, nurses, psychologists, and social workers. The medical care should be based on guidelines, but should nevertheless respect patients' decisions even if they differ. We'd love to see cooperation instead of competition. Doctors should not hesitate to contact specialists if necessary. Patients need information about the disease they can understand. They need information in their native language. They need better recommendations for young women about pregnancy and delivery and its impact on the outcome of their disease. They need more recommendations on lifestyle, nutrition, and everyday life. Emergency training for family members is recommended. We could create booklets for patients from the patient's perspective and translate them from English into other languages. We could do educational videos for patients, either English videos with subtitles or videos in the native language. By the way, Esther Costa-Freire is just working on a draft of a video for ARVC patients. In this respect, it's not such a good idea to have this talk today in English, but unfortunately I don't speak Spanish. We need meetings like this one today, with expert information for patients and non-specialist doctors, and the opportunity for patients to exchange with fellow sufferers. In COVID-19 times, it's a good idea to have it online instead of cancelling it. We need transversal working groups between experts and patient advocates of different disciplines. For example, cardiologists and gynecologists for pregnancy and family planning. A new transversal working group with doctors and patient advocates just started within the European reference networks, and I'll be part of it. Training sessions for cardiopulmonary resuscitation for family members or in school for teachers and classmates of affected pupils can be helpful to reduce fears. I have a dream that all these dreams will come true one day and that our children did not die in vain. Gracias.